go. You did it. So welcome, everyone. We're just having everybody join in, and we'll get started in a few minutes. Thank you so much for joining. And I see lots of familiar names in the attendee list, so welcome, everyone. Don't worry, I'm not going to call anybody out by name. You're all safe. No, probably. So David, there's already one question in the chat that is going to be for you. We might have a look at that in the question and answer, I mean. So you might have a look at that while you're getting ready there.
I'm going to cover that sort of.
Yeah, I know you are. Just letting you know it's there.
Sort of. You can't. I need another 30 minutes to.
All right, well, it is 6 o'clock and we have just hit the magic 100 number. We're supposed to have, we have over 300 registered. So I'm going to give it just another minute and then we're going to get started with the intro, which I can go through fairly quickly. Then we can get into the meat of this. So literally I will start in 1 minute, everybody. So Dave, you can just have a look at the Q&As and you can, while I'm talking, you can be ready for those questions or answer them in the talk. And I'll deal with getting rid of them once we've answered them and so on. So just gives you a little bit of chance. All right, so I think we're going to get started then, everyone. Thank you so much for joining. We have people still joining, so I apologize to those people who are just getting in now. But I thought we'd start on time because we actually have a fair bit to cover between David and I. So my name is Alan Kaplan. I'm a family doctor. My office is in Aurora, and I'm the regional primary care cancer lead. David, why don't you introduce yourself?
My name is David Barron. I'm a gastroenterologist at North York General and the lead for endoscopy and colon cancer screening in Ireland.
So I'm going to give a quick intro. David's going to talk about colorectal cancer screening. I'm going to go back and talk about lung cancer screening. As many of you know, I'm the chair of the Family Physician Airways Group of Canada, so I have a keen interest in respiratory medicine. So this sort of does follow along my bailiwick, although I'm not a respirologist by any means, and I do not treat lung cancer. So there's my front there. So we're going to record this, as you know. Again, chat function to interact and say hello, Q&A for ask the questions, so we keep those. If you're having any issues, then Rukaya as the person to contact. Here's her email there. raladina@southlakeregional.org. In addition, if there's questions that you want to pose to David or I, then please go ahead and send her an email those questions and we will get back to you. We're going to send you these slides and a link to a recording afterwards. There will be an evaluation. Please spend a moment to do that. And this is accredited for two credits for the family physicians on the call, and you'll be getting your certificate for that afterwards. Quick land acknowledgement, the Central Regional Cancer Program, which is located at South Lake and Newmarket, recognizes that the lands are being used from First Peoples of the Williams Treaties, First Nations, and other Indigenous peoples. We have a group in the Georgina Island First Nation that come from the Chippewas. So we want to recognize that we have a relationship to the Chippewas, particularly with the land and waters of our territory. And we hope to continue being good stewards of these lands and the waters over time with them. So here's my disclosure slide. I work with a lot of different companies for a lot of issues. I'm involved in some other Health Canada initiatives as well. None of this has anything to do with this talk today. And there's been no financial support given. Obviously, we have Rakaya, who's done a wonderful job in helping us get this all set up, so in-kind support. And my only conflict of interest is that one of my jobs is the primary care cancer lead. And my bias is that I think that we can do a good and even better job in improving primary care cancer screening in our region. And so with this discussion, we're going to move on. So overall, we're going to talk about current guidelines for colon and lung cancer screening. We're going to talk about some special considerations about the pandemic very quickly now, and what we can do to catch up over time. We talk about screening, as you know, the idea first of course would be prevention. Would be great. We're going to talk mostly about screening, but the cancer journey is much longer than that. It includes making a diagnosis, firmly treating, and then either end-of-life care or recovery. And this is all very relevant, with palliative care being something more and more necessary. But the good news and bad news is if you're sort of looking here over time, cancer rates are actually increasing. New cancers incidence is actually increasing over time. But there's still a significant risk of death from cancer, which is still the #1 cause of death in Ontario. So that's the bad news. And these are older data, as you can see from the graph there. But the good news is that actually cancer mortality overall, even though there's more cases, but the mortality is actually going down. So we have more and more treatments, be it chemotherapy, targeted immunotherapy for different cancers that we can do to make a big difference. So it's really exciting to be able to do this. And we have a lot of people now who are surviving and living with cancer, living with the effects of the treatment of cancer, whether it's still being at risk immunologically with everything that's happened with COVID and should they be vaccinated? Yes. Whether it's side effects of different chemotherapy or radiotherapy and neuropathic pain, regardless what it is, there's a lot of people out there who are still in the cancer journey in the survivorship stage. So we should consider that as well. But we're going to move on to screening. So our job in primary care is to identify who should need it, help them make decisions if they're unclear, arrange, facilitate, and conduct those screening tests, and importantly, arrange follow-up of abnormal tests. That's going to be a very important step. There's no point in doing the test if we don't act on it. But the big message here for primary care to take away is what we say is important. I know sometimes you feel like what we say sort of goes in one ear and out the other, but the reality is that our recommendation makes a huge difference in what patients do, be it vaccination or be it screening. So please empower your patients to get this done. We have 4 organized cancer screening programs. We're going to talk about colorectal and lung screening today, and next week we're going to talk about breast and cervix. The big picture with COVID is this picture here, and I showed it a couple times in individual cancers, but we had a huge fall off with COVID. All the resources went to treating COVID, and now we're getting back to that again, and we're doing a very good job with that. So here's colon cancer. And David, I don't think you're showing this particular slide, but this just showed the big fall. And now we've recovered back to above what we were in our pre-pandemic launch for FIT. And where we also want to consider is how good of a job we're doing on dealing with the abnormals. And you can see there was a bit of a dip there just where there wasn't place to do the colonoscopies in the hospital, but we've now recovered well. So as a rule, all of our specialists have done a really good job throughout all this time in dealing with abnormalities. The target is 80%, within 8 weeks. David's going to talk about that. I'd like that to be higher, and so would everybody else. In terms of mammograms, you can see the same fall and then the recovery, but tissue biopsies really didn't fall when abnormal tests. So it's the same message across. Pap smears fell, hasn't quite recovered, There's a lot of doctors still doing a lot of virtual care. If you can figure out how to do a pap smear through the telephone, let me know. It's not really so easy to do, but you can see colposcopy is still pretty close to the rates we did before. So our specialists have really stepped up and have done the job with the abnormal screening test, which is great. That all being said, it's not completely okay. So here's some work that's been done to show the difference. This is from March 2020 to December 2021. So again, these were all those people that didn't get the screening test done. So whether you're talking about colon cancer, where there's probably 127 people that didn't have cancer detected with a risk of mortality about 6, breast screening 231, risk mortality 10, cervical screening 136, risk of mortality of 6. So we had costs. There were definite absolute costs of the pandemic, decreased screening, and now we want to make sure that we catch up and it doesn't happen anymore, because we're going to have a lot of people now who are being screened, and we may find later cancers because of the delay. So our plan really is to talk about the best practice in cancer screening both this week and next week. I'll give you some resources to help, and I want us to get excited about being primary care doctors again and doing the preventative things that we can do, and being able to do screening possibly. So I'll stop sharing now and move on to Dr. Barron to talk about colorectal cancer screening. There you go.
See my slides? Oh, shoot.
Not yet. There you go. No, you're good. There it goes.
Oh, there we go. You see it?
Yep.
Thank you, Alan. Thank you very much. Welcome, everybody. I was blown away by the number of people that have actually signed up for this webinar. So welcome to everybody. I'm going to be talking about colorectal cancer screening in Ontario, and mostly talking about FIT and the advantages of FIT. These are my conflict of interest and disclosures. These are our CanMed rules. And these are the learning objectives that I'm going to talk about to describe and understand FIT testing, to show you evidence that supports FIT instead of colonoscopy for average risk individuals, to understand the outcomes of a FIT positive colonoscopy, to understand Ontario Health or Cancer Care's position on post-polypectomy surveillance, and to give you some central region FIT data that Alan has showed you some, but I'll continue to show you more. So just to remind you that colon cancer check was actually started in 2008 with fecal occult blood. And then in June of 2019, it was switched over to FIT. This is designed for average risk individuals. If patients are at increased risk, we do suggest a colonoscopy. So if you look on the slide on the left side, you can see who should be screened, who are the average risk individuals. This is anybody between the ages of 50 and 74. And that's according to the program. Now, many patients ask me, or many physicians ask me, what about 75 to 85? And I say, yes, if they're healthy, I would suggest they be screened. They need to be asymptomatic, no first-degree relatives with colon cancer, no personal history of colon cancer or inflammatory bowel disease, and no history of polyps. They have to have OHIP coverage, I guess. They have to be due for screening, and the recommendation is for a FIT. If the FIT test is normal, then they should have a FIT every 2 years until 75, and again, possibly 85. If it's abnormal, in other words, it comes back positive, a colonoscopy should be performed within 8 weeks. If that's normal, you don't need to repeat a FIT for 10 years. Already there was one question in the box about whether we should do FITs between normal colonoscopy, and there is no indication to do that. If the colonoscopy is abnormal, then we need to treat whatever we find. So the other tests that people ask about, more patients than physicians, I've listed down there below, and none of them are recommended for average risk screening. So remember, this is how a FIT is done. It's really easier, much easier than the fecal occult blood test of old. The patient is mailed a kit. They take a sample of their stool with that little stick. They put it in that little jar, tighten it up, send it off to the government, and the government will, LifeLab's government will send you the result within several days. Also, patients get the results as well. So how does it compare to fecal occult blood testing, which we don't do anymore? Well, it's far more sensitive and just as specific. There's a lower limit of blood detection. And the good thing about it is that nothing interferes with it. So we don't have to worry about stopping any medications to do this test. And if you compare the sensitivity with FIT, it's about 82%, whereas fecal occult blood test was 38%. That's why a lot of us thought that it was a pretty useless test. and didn't always recommend it. But I think FIT has shown it's far more sensitive, and it's just as specific as fecal occult blood testing. The other big advantage is when you compare participation rates for fecal occult blood tests compared for FIT compared to fecal occult blood test, about 16% of patients prefer FIT to FOBT, and their participation rate is higher. And also the detection rate for colorectal cancer and high-risk adenomas is about 2 to 1. So it's a good test, and patients don't mind doing it. What about flexible sigmoidoscopy? As you know, we have been endorsing FlexSig as one of the options in the province of doing screening. It just never took off in the province. And this is a recent study done in 2020 comparing sigmoidoscopy to 3 rounds of FIT. And you can see that on the left bar, there's this is detection rate of colorectal cancer. And you can see one sigmoidoscopy, it's 0.27. And if you've done 3 FITs, your rate of finding cancer is twice as high as doing a flexible sigmoidoscopy. So very effective. When you talk about high-risk adenomas or advanced adenomas, one flexible sigmoidoscopy will detect 2.4, whereas in the first FIT round, you don't find as many, but after 3, you detect just as many. So in my mind, it's better than doing flexible sigmoidoscopy. What about colonoscopy? And this is the big question. We always get this from our patients. Should I have a colonoscopy? Should I have a FIT? Which one's better? I'll try to answer that today. So this was a study, and I'm sorry it's a little bit blurry, but this was out of the New England Journal in October of 2022, and it caused a lot of problems in the GI community because the results were a little bit disappointing. So the upper bars are the primary endpoint of colorectal cancer detection and mortality. And they looked at patients who had usual treatment versus those who were invited to have a colonoscopy. So this is colon cancer detection rate, and it was 0.98 for those who were in the colonoscopy group, and 1.2 who was average screening, not screening, regular care. And it's not a great big difference. And even for mortality, which is this bar, there wasn't a huge difference. But I think the problem was if you look at the per protocol, these are patients that actually had a colonoscopy versus those who were invited to have a colonoscopy. So this is as screened, not as an intention to screen. And you can see the results are certainly better. So if you've actually had a colonoscopy and you've agreed to a colonoscopy, your chance of finding colon cancer and having colon cancer after 10 years is much lower than in the routine care group. And the mortality rate you can see here is much lower at 10 years. So I think if patients actually have the colonoscopy, it's a good test. But I think what we're finding is patients often don't want to have that colonoscopy. And what was very disappointing was that the actual mortality rate from all causes in both groups was the same. So whether you had a colonoscopy or had usual care, your chance of being dead in 10 years was exactly the same. So this was a Spanish study comparing fecal FIT testing to colonoscopy out of Spain. This was a large randomized control trial. They include patients between ages of 50 and 69. They mailed participation, and it was to have biannual, every 2-year FIT test versus one-time colonoscopy. Primary outcome was colorectal cancer death, and this study only reflected the first round. So not every 2 years, which what we're recommending. And this was very interesting. So they invited 25,000 people in each group, the FIT group and for colonoscopy. In the FIT group, 30% of patients responded and were willing to participate, whereas in the colonoscopy group, only 28% responded. And they were allowed to cross over. In other words, if you were invited to do a FIT and you said to your doctor, listen, I don't want a FIT, I want a colonoscopy, you could do that. And 1% of patients who were offered FIT actually did the colonoscopy. But of 28 patients who were offered a colonoscopy, of 28% who responded, who said they were in the colonoscopy group, 23% of them actually said, no, I'm not going ahead with a colonoscopy, I'm going to have a FIT test. So right away, we can see this is a huge difference. And patients, I don't think, want colonoscopies if there are other tests around. So there was almost a 2-to-1 completion rate for FITs as compared to colonoscopy. And there's no question that patients prefer FITs. And what did the results show? Well, for colorectal cancer detection, there was absolutely no difference in the two groups. So in the colonoscopy group, 30 were detected. In the FIT group, 33 were detected. High-risk adenomas on one FIT, remember this is only on one FIT result, was much lower in the FIT group than the colonoscopy group. The number needed to screen to find one cancer was a little bit higher in the FIT group, so 281 versus 191, but the number of scopes you needed to do to find one cancer was much, much lower in the FIT group, 18 compared to almost 200 in the colonoscopy group. And the number of complications were much higher in the colonoscopy group than in the FIT group. So again, I put this up to remind you that FIT is a program. It's not to be done once and then forget about it. It needs to be done every 2 years. And you can see here that every 2 years goes by, your chance of finding a high-risk adenoma goes up, and your cumulative rate after 10 years, which is 5 FIT tests, is 60% in finding a high-risk adenoma and almost 10% in finding a colon cancer. So again, regular screening every 2 years is an important part of the FIT program. This was a study out of the Netherlands looking at FIT for 4 rounds versus colonoscopy for 1 round, so 1 colonoscopy versus flexible sigmoidoscopy. And again, I highlight the participation rate was 3 times as high in the FIT than the colonoscopy. So if you have a test that nobody wants to do, why are we doing that test? Colorectal cancer detection, and this is an as screen. So they actually had the FIT test, they actually had the colonoscopy, and they actually had the flexible sigmoidoscopy. And you can see the colorectal cancer detection rate was higher in the FIT group than in the colonoscopy group. The advanced adenoma detection rate was lower, 5.4% versus 8.5%. On an intention to treat group, in other words, when they divided these 3 groups into flex sig, colonoscopy, and FIT, and then they saw at the end what their detection rate, you can see it's much higher in the FIT group because more people are doing it. So it's 0.6 for colorectal detection in FIT versus 0.2 in colonoscopy. And even in advanced adenomas, after 4 rounds, it's twice as high as it is with colonoscopy, because again, I don't think patients are going for the colonoscopies. This is just another way to look at the same data. Whoops, sorry. So this is for on an as screen basis. So these are actually patients that had a colonoscopy or had a FIT, that the colorectal cancer detection rate is about the same in both groups. Advanced adenoma is a little bit higher in the colonoscopy group. And this is as per protocol, which is they were put in the colonoscopy group, but may not have had the colonoscopy. You can see the results are much higher in finding colorectal cancers and in finding advanced adenomas in the FIT group versus the colonoscopy group. And again, just to remind you, colonoscopy does have risk, and this is Ontario data. So the chance of bleeding after colonoscopy is 1.64 per 1,000. The chance of perforation is 0.85 per 1,000. So I quote a 1 in 1,000 rate of perforation. And so what's the difference when we do an average risk colonoscopy versus a FIT positive? So an average risk colonoscopy, we will find less than 1% cancers. We will find 5% advanced adenomas. We will find 25% low risk adenomas, and we will find 65% that are absolutely normal. Whereas if we're sent a FIT positive patient, there's almost a 5% chance we're going to find a cancer. There's a 25 to 30% chance we'll find an advanced adenoma, which are these high risk polyps. And there's another 25, 30% chance we'll find low risk adenoma. So when we do a FIT positive colonoscopy, 60% of the time we're finding pathology. So to give you just a modeling look at this, if you take average risk colonoscopy you do an average risk colonoscopy versus FIT positive colonoscopy, if we scope 100,000 patients in each group, we will find 400 colon cancers in the average risk colonoscopy and 8,000 colon cancers in the FIT positive colonoscopies. We will find 10,000 high risk adenomas in the average risk and 45,000 in the FIT positive group. So we can screen 1.8 million people with FIT if we do 100,000 colonoscopies, whereas we can only screen 100,000 people if we do 100,000 colonoscopies. And just to give you an idea, in Ontario, we do about 450,000 colonoscopies per year. That's in the whole province. So in summary, I think patients prefer FIT. I think FIT is certainly safer than a colonoscopy. FIT is as good as a colonoscopy in detecting colon cancer, and the positivity rate on a FIT positive colonoscopy is very high. So that's why we recommend FIT over colonoscopy. What about follow-up? Well, patients, if they have a positive FIT test, should have a colonoscopy within 8 weeks. An abnormal FIT is associated with a higher chance of actually having colon cancer. And if you delay diagnosis more than 6 months, you have a much higher chance of finding a metastatic or a high-risk cancer. And this is an older study from 2017 that shows that patients who have an abnormal FIT who don't have a colonoscopy, and this is the dotted line, are more likely to die from colorectal cancer. And there's a 1.63-fold increase. So if patient has a positive FIT, they need a colonoscopy. And again, this is data showing that in the first 6 months after a positive FIT, the chance of finding colon cancer, whether it's month 1 or month 6, is about 3%. And an advanced stage cancer, which is stage C and D, or 3 and 4, is about 0.8. Whereas after 7 months, the risk of cancer goes up to almost 5 to 8%. And the high risk of a high risk or advanced cancer is 1.5 or up to 3%. And on a ratio basis, this shows the exact same thing, that after 12 months, your chance of having an advanced cancer is 3 times as high if you don't have a FIT within the first 6 months. We suggest, for anxiety reasons on behalf of the patient, that within 8 weeks is the target, and that's the target that Ontario Health has set. So this is just some data. Some of it Alan has shown already. This is our data. This is central data. And you can see the number of fecal tests per month and per year. And you can see the dip here during COVID. And the purple line is 2022. And we're almost, but not quite back to the same number we were at before COVID started. So we still have a little ways to go. This is overdue for screening. So these are patients between the ages of 50 and 74 who have not had a flexible sigmoidoscopy, a colonoscopy, or a FIT test at their due time. And you can see here that the target for the province is 40%. That's still quite high. That means 40% of patients are not getting screened. During COVID, we were falling behind, but now you can see that the number is dipped just below the target, and Arlene is at 38.9%. Well below target, but I think as a group, we can do much better. And again, this is abnormal colonoscopy done after a positive FIT. The target is 20% or 19%. And you can see that during COVID and post-COVID, we were up around that mark, but now we're about 10%. But I think even 10% is way too high. Anybody with a positive FIT should have a colonoscopy. What about outpatient colonoscopy volumes in our LIN? We do about 6,000 or 7,000 colonoscopies in our LIN. This is both out of hospital facilities and in hospital facilities. And again, the purple line is this last 2022. And you can see the numbers are starting to creep up again, whereas in COVID, they just dropped off the map. And I tell my patients, I lost 1,000 colonoscopies during COVID. And that's why my waiting list is so long for colonoscopy, because I'm catching up on people that I saw in 2021. We do get urgent patients in, but for family history, routine follow-up, we're delaying people because we have so much volume to catch up. And I show this slide because it shows the indications for colonoscopy. The green bar is average risk screening, and the blue bar down here is FIT positive screening. And you can see early in the year, last year, we were a fair number, about 7 or 8%, but that's dropped off over the year. The trend is down, whereas the trend for average risk screening has gone back up. So I think we're doing far more average risk screenings than we should be, and we should be doing more FITs because those are the higher yields. Remember, the average risk screening yield, like I showed in my previous slides, is very low. So if we can convert all those average risk screens to FITs, the backlog that we have now, we will be able to whittle down. So if we convert none of those average risk colonoscopies to FITs, our backup is estimated to be at 23,000 patients. That is going to take, we only do 60,000 a year. So that is a huge backlog. If we're able to convert 75% of average risk colonoscopies to FIT, our backlog is only 3,000. And between this province, between our LIN alone, we should be able to catch up on that fairly quickly. So just to give you an idea that in our LIN, we're doing twice as many average risk screening at 3,775 than we are FIT testing at 1,800. There's some hospitals, and I'm going to use my hospital because I'm very proud of this number, that we only do 4% of our cases are done for average risk screens, whereas other hospitals are somewhere between 25 and 30%. And remember, average risk screen colonoscopies have a very low yield. This gives you an idea of out of hospital, which is the brown bar, and in hospital, which is the blue bar. It's split in our LIN at 50-50. We have the highest number of out of hospital facilities in the province. But almost all the FITs are done in hospital, which I think is appropriate, with about 17% done in out of hospital facilities. And this is the wait time that Alan talked about before. That the benchmark is 56 days, where 75% of the patients who had a positive FIT should have a colonoscopy within 56 days. Okay, and you can see we're kind of right at that. And this number is actually divided into two. The brown bar is abnormal result to referral. So the result comes to your office, and then you send the referral off. And then the second, which is the green bar, is referral to colonoscopy. And the blue bar is the total time. And you can see if you look here that about half the time is because we're not getting the referral, and the other half of the time is because we get the referral and it takes us time to actually do the colonoscopy. So in our LIN, our average wait time is 57 days, very close to the 56, but half that time is because we are not getting the referral in. And again, I'm going to use my hospital as an example. Once a referral is sent to our hospital, the average wait time is 9 days to get a colonoscopy. Whereas it's taking, in our region that send us patient, it's taking 47 days from the time of the abnormal test to the time of referral. So I encourage everybody on the line today, when you get a positive test, please send the referral in so we can get the colonoscopy done. What about post-polypectomy follow-up? Well, these are the current guidelines. If the patient has no polyps or hyperplastic polyps, they should have a FIT test at 10 years. They do not need to have a FIT test in between. If they have a low-risk adenoma, they should have a FIT test at 5 years. And if they have a high-risk adenoma, then they should have a colonoscopy at 3 years, and that's unchanged. So a lot of people are very nervous about this fact that you have a polyp and you're not doing a colonoscopy at 5 years. This is what we used to tell our patients as recently as 2 and 3 years ago. So people get quite nervous about that, but this is data to support that. So if you look here, if you have the yellow line is no adenoma at time of colonoscopy, the blue line is a non-advanced adenoma, and the black line is an advanced adenoma. If you had no adenoma or a low-risk adenoma, you had exactly the same risk of having colon cancer at year 15. So it's the same risk. There's no difference in risk, versus if you've had an advanced adenoma, your risk is double at 15 years of having colon cancer at that time. So that's why we say for low-risk adenomas, FIT test 5 years. Even if you look at mortality, the mortality rate for patients who have a low-risk adenoma compared to normal is the same. And in fact, if you had a low-risk adenoma, your mortality rate may be even a little lower than a patient who had no adenoma at all, which is interesting. So again, patient has a low-risk adenoma, we recommend FIT at 5 years. And finally, for high-risk adenomas, colonoscopy at 3 years, and then at that 3-year colonoscopy, if there's another high-risk polyp, you do it at 3 years again. If there's no high-risk polyp or low-risk adenoma, you do it every 5 years. I was asked about family history. So this is a talk on its own. So it really depends on the age of the first-degree relative. So my cutoff is between 60 and 65. And I say that because it depends which guidelines you read as to whether it's 60 or 65. But it's the first-degree relative. So anybody over the first-degree relative over the age of 65, I suggest a FIT and consider them average risk. It depends on the number of relatives who've had it. So if you have multiple first and second-degree relatives, I think these patients are higher risk. It depends if your first-degree relative had a cancer or a polyp. And I think it depends on what type of polyp the first-degree relative had. So if your mother, for example, had a high-risk adenoma at 50, I would consider that a high-risk individual. Whereas if they had a low-risk adenoma, I would consider that an average-risk individual and probably should have a FIT. But it gets to be a little bit complicated. The biggest complication is we often don't have the pathology from the first-degree relative who had the polyp. And that's when we don't know what to do. So that's the end of my talk. I think I went a little bit over, but Alan said he would give me a few minutes from his talk. If there are any questions, I'm happy to answer them.
So David, why don't you stop sharing right now? And I'll jump into my talk. There's a number of questions in both the Q&A and the chat. So have a look at some of those and organize your thought in terms of answering such. And oh my goodness, let's get out of that and open up this one. So I'm going to get into the lung cancer talk quickly while you're doing that. So lung cancer screening is important because really it's the leading cause of cancer death people in Ontario as of 2020 and still now, I'm sure. 2020, they talked about over 7,000 people expected to die of lung cancer, which is higher than the combination of colon, breast, and prostate altogether. So relatively, it's very important. And like every other screening, in order to screen, you have to show that screening makes a difference. And it does. It's been clear that that actually does work, that lung cancer, if diagnosed at an earlier stage, will make a difference. So we can do that. So not all screening, as you know, has the same benefits. We could talk for hours about the debates about prostate cancer screening, for instance. So the screening issue of screening is that we have to be able to do something about it. So the evidence for this comes from two big trials. In the United States, the National Lung Screening Trial looked at 50,000 people between the ages of 55 and 74, 30-pack year smoking, either currently smoking or have smoked. These are people with screening, so they're people without symptoms or any issues like that. And they compared it to chest X-ray, which is an interesting thing to compare, being that chest X-ray screening is pretty well useless. And I will show you some data about that. And it showed that there was a 20% reduction in mortality at 6 years. So the first thing, and that 55 to 74 30-pack years is still what we use as our indication. Then the Nelson trial, which was 15,000 people in Dutch and in Netherlands and Belgium, again, looking at people at high risk of cancer, which of course is going to be mostly smokers, looked at lung cancer screening at 4 different time points compared to no screening at all. And similar kind of numbers, a 24% reduction in lung mortality in men. Interestingly, a higher reduction in women, 33%, although because of numbers, it wasn't statistically significant, but I think that was just a numbers thing. So again, we have two big studies in big populations that have shown that lung cancer screening can make a difference in mortality. So what we really want to do is have an organized lung cancer screening program. And as some of you recognize, this is only available in a few places, which I'll talk about. We use low-dose CT screening, not ordinary CT scans. That's important. It's important that we include smoking cessation as part of this. And there continues to be absolutely no value for chest X-ray screening. So when people say can have a chest X-ray to look for cancer as a screen, the answer is no. They have a chest X-ray because they have symptoms. That's different, and I'll talk about that. So way back in the early 1980s at the Mayo Clinic, they did this chest X-ray screening program. There's a chest X-ray every 4 months in high-risk patients, over 45, heavy smokers, as a pack-a-day smokers, and there was absolutely no improvement. They did find more cancers, as you'd expect. But by the time they found those cancers, it was too late to do anything. So by the time you see a cancer on an X-ray, then unfortunately, it's likely going to be too late to do a whole lot for them. Now, that doesn't mean if you find an incidental nodule on chest X-ray, you just say, you're going to die, it's too late. No, you're still going to work it up because you're not going to ignore it, of course. But that's again, the likelihood of having a really good result on an incidental nodule is not quite as good as a screening program as you would imagine. So what about just doing it as you sort of, in your practice? I'm just going to start doing lung cancer screening. I'm going to order low dose CT scans and screens on my people at high risk. How about doing that? Well, a couple of things about that. First of all, you have to make sure that you've got the indication properly, and it's something we have to learn to be available. We have to make sure they get a low dose CT scan. They don't get a regular CT with intravenous contrast because they don't need it. Again, this is for screening. And again, once you do any screening program, you're going to actually get people who have false positives, and you're going to find stuff, which is going to be an issue regardless. But the biggest reason for not doing opportunistic lung cancer screening is it's really hard work. This is the Fleischner criteria for managing incidental pulmonary nodules. So you do a CT scan for abdominal pain and they see a nodule. Or you do a CT scan for pulmonary embolism and you see a nodule. So these are how you find it. So as you can see, solid nodules, subsolid nodules, low, who are considered low and high risk, and the different follow-up, whether it's 3 months or 12 months or not at all, and who should be biopsied right away. This is everything that you actually have to know if you're going to take on, opportunistic screening in your office on your own. So recognize that the lung cancer screening programs, they have a navigator, they have someone to take the patient through the process. They do risk assessments that include more than just age and smoking cessation, which I'll talk about. And they've got someone who's going to act on the nodules, and I'll talk about that. So I think there's some medical legal implications in this and to do this. And even with these incidental ones, this is a lot of work and a lot of follow-up. And you got to make sure, because if it doesn't get done, you're on the hook for not following it. So I think we should let screening programs do this properly. And if you want to do this individually, all the power to you. But again, and I must admit, I do it for a few patients locally, but it's really hard work, and you have to know these Fleischner criteria are pretty solid or have to have availability of them. So again, good idea, but probably going to be more work than you're prepared to do. So again, overall, this organized lung cancer screening program, we're going to use low dose CT because it does decrease the risk. We have a navigator to take you through the system. We have standardized reports, which is really important. So the reports all look the same. And I'll show you that in just a moment. Smoking cessation services are included in it. They're going to go through this navigator for a risk assessment. And if they do need to have lung diagnostic testing, it's all arranged. You don't have to arrange it. It's part of the process, right? So again, there's risks. You can radiation is still there, even if it's low dose CT. You're going to have false positives. And what happens in all screening programs is we're discovering, although it's hard to show which ones they are, is we probably find some tumors that probably never would have gone on to become aggressive. But you don't know that at the time you find them. We found that with breast cancer. We found some cancers that probably would never have gone on to be a problem. Same with lung cancers. And so it's possible there. But again, to me, I think that I'll take that as a good outcome rather than consider it a risk. So in Ontario, we had the lung cancer screening project for people at high risk in June 2017, based on the first trial, the National Lung Screening Program I talked about. It ended in March 2021, and it was an overwhelming success. We had significant improvements in lung cancer detection, improvements in presumptive mortality based on the cancers that were picked up. They were only done in level 1 thoracic surgery center hospitals. They had to be applied for. They had to have an on-site program for all this. And they're still available at those 4 sites. So the 4 sites are Lakeridge in the East End there, Ottawa, University Health Network is still TGH downtown, and in Sudbury, the Health Sciences North. So all of these is a very powerful pilot. It was positive. You can still refer to these sites, which I know is probably far for a lot of your patients who are on this call. There are some hospitals that have taken this program on outside of Cancer Ontario, and they're doing a wonderful job. Grantham Civic, which I've had some involvement with when I worked there, they're doing a fantastic job. They've hired their own navigator. They have thoracic surgeons on site. They have respirologists on site, all of whom have bought in. They have a smoking cessation service. So it can be done, but this requires the hospital to put in a fair bit of resources to make sure it's all happening properly. In other hospitals, you can order your low-dose CT scan, but you're not going to get the navigator and the follow-up and the routine of everything happening. So again, yes, right now this is a barrier. At every Cancer Care Ontario meeting I'm at, I have the same questions. They're starting to get tired of me. When are we going to get this in other areas? Sunnybrook, we're sort of working on this right now because that's the major hub for our central region. And there's surgeons there that are on board, and the radiologists are developing on board. So we're developing a program and just waiting for the funding to come from Ontario. So the indications are really that of smoking and age history we talked about, but there's increased risk in other conditions. COPD, especially emphysema, may be factored in. Actually, alpha-1 antitrypsin is an increased risk. So I'm not going to go through the entire risk calculation, but instead of just looking at age and years smoking, they actually take these other factors in to criteria as well. If they are considered not necessary to have screening because they're low risk, this will be explained to them in detail. You don't have to get in the middle of that. You'll be sent a report explaining it, but they're still going to get offered smoking cessation. So we're fine tuning who gets screened. It's not just based on numbers anymore. It's going to be based on risk. I'm going to show you a little bit of data that explains this. So this is, first of all, if you have COPD and develop lung cancer, it probably doesn't surprise you that your survival rate falls significantly if you get lung cancer on top of your COPD. That's probably not a surprise to any of you. So you can see the difference between those that did not and those did develop lung cancer in terms of survival. In addition, the worse the COPD, the higher the risk of lung cancer. So it is postulated that some of the same processes in cigarette smoke, especially, that causes the damage that causes COPD, may also cause the damage that causes teratogenicity. So that's probably related. So you also see restrictive lung disease is also a bit higher than people with normal lung function. So these are other conditions, not just COPD. So the worse your lung disease is, the higher risk of cancer is. So again, these are things that the risk navigators actually take into account. This is a piece of work that looked at the risk of emphysema in lung cancer, and they did a meta-analysis of a number of different trials. And you can see down at the bottom that it's quite clear that emphysema itself is a risk factor for having lung cancer. And emphysema is not the same as COPD. COPD means they have obstruction on their spirometry. Emphysema is what you see on an X-ray or a CT scan. That's a radiologic finding. So these are both separate risk factors for having lung cancer. Now, I said screening is for patients who do not have symptoms. So for everything, there were some questions before as well. What about constipation for screening? What about bleeding for screening? Well, no, these are people who are in your mind are high risk of having a disease process that require investigation. You do not put them in the screening program. And similarly with lung cancer, if you got people with these symptoms that you're worried about lung cancer, they do not get sent for a low dose CT scan for screening. They get sent for a regular CT scan with written down what the symptoms are and worried about lung cancer. So they do more cuts and they do intravenous contrast to get a better look at it. You want that to happen. So people that have hemoptysis, people that are losing weight, and having a worse cough if they're smokers, they're getting shorter breath and you've ruled out other issues. People with non-resolving pneumonias, because maybe they have a post-obstructive pneumonia, may be necessary. People with a unilateral wheeze. I mean, a whole bunch of things that would make you think about cancer. They do not get sent to the screening program. They get investigated properly. So what do you get when you do the CT scan and you do the program? You get a couple of printouts. Within a couple of weeks, you get the response. So the standardized report will have, first of all, the lung issues. So is there any nodules at all? If they are, how big they are? And they score them on something called the lung RAD score. If the lung RAD score is high, where the risk of cancer is high, they arrange all the follow-up. You don't have to do anything except support your patient. But what you're also going to get is incidental findings, because you're taking a picture of an awful lot of the body when you get a CT. So we see all kinds of things that can happen. When we see aneurysms, you see osteoporotic fractures, you see breast nodules, thyroid nodules, see all kinds of things. That is your responsibility to follow. You will get a message from the radiologist about advice for next step, which you can listen to or not, but that's your job. So the lung disease in the organized program, you don't have to take care of. Other than if you get something like emphysema or COPD, you'd want to take care of that. But those incidental findings, they're going to leave you to deal with. So please don't ignore them, because you're medical legally liable for them. So again, here's the process. So I've just gone through that. They get a referral, they get a risk assessment, they get the CT, and then they get communicated to them their next steps. So if their lung RAD score is high, they're going to be referred on in the center for the next assessment, a diagnostic assessment, which, depending on how high the scores, will include a biopsy. So those incidental findings I've mentioned, I'm just going to reiterate here how important it is for you to follow that up. So again, if they got nodules, you know how to follow that up. If they have emphysema, they should be sent on for lung function testing, especially just spirometry to see if they have COPD, and so on, coronary calcification. Then you start thinking about coronary risk and you get the idea. These are all things you need to do. So here's just one example. If the intermediate renal nodule, which is a simple renal cyst, they tell you no further evaluation. It could be an angiolipoma. It could just be a simple cyst. You don't have to do anything. So you've got the report that says you don't have to do anything. But if there's something else, then the reading radiologist will give you some advice. So is it an ultrasound? Is it further imaging? And so on. And they'll say this is actionable, right? So they'll highlight for you. There's no subtlety to these reports. Not actionable, actionable. So the recommendations are listed. That's our job as family doctors to follow up. And again, I'll say it, please do not ignore these because medical legally, you're on the hook for those. They're not going to be dealt with by the screening program. So is it also an opportunity for COPD and assessment? So it's a good time to think about spirometry for your smokers if you haven't had it done, and especially if they have any symptoms, because you're going to find people with undiagnosed COPD, which is, again, a target for an entire other talk, which I won't get into. But remember, we first have to diagnose COPD, especially if they're symptomatic. So this is called the Canada Lung Health Test. And if you're 40 or older and you're a smoker or used to smoke and you have cough or phlegm or shortness of breath or wheezing or frequent chest infections, get spirometry done because they've got COPD. And this isn't screening for COPD. This is case finding, and it should be acted upon. And of course, smoking and lung cancer, you all know this. You can see that the better the lung function, the lower risk of lung cancer. I showed you that already, but the bigger the effect of smoking cessation as well, right? So again, smoking, if you keep smoking, your risk is higher. If you quit smoking, your risk is lower. If you stop and start your smoking, it's a little bit better, but what you really want to get people to do is quit smoking entirely. That's our goal. So you do get smoking cessation support. You're going to get a counseling session, at least 10 minutes with a trained facilitator. You're going to be offered pharmacotherapy and follow-up and opportunity for doing that. And again, if they're ineligible for screening entirely, they'll also be offered a referral to Telehealth Ontario or the Smokers Helpline. So we're going to get some help on the smoking cessation part. In terms of the central region, we have a few different resources available. I thank Brianna for the slide. So Health Connect Ontario, is a free program available by phone or text in 100 languages to help people with quitting smoking, vaping, and other tobacco use, like hookah, for instance. Talk Tobacco, this is for First Nations people more directly. 24 different Indigenous languages, again, phone, online chat, and text. KMH has a relationship with the central region now, so we're now able to offer up to 8 weeks of nicotine replacement therapy through the KMH program that's been doing this for a long time, as many of you know, as well as counseling. And drug benefits, as you know, do cover both Champix or varenicline or Zyban bupropion every 12 months for smoking cessation for 12-week therapy once a year. So we have lots of resources there. Now, do we have everything covered when it comes to lung cancer screening? And this is just more to facilitate thought down the road, because I think we have to recognize there are going to be other people that are higher risk. This interesting article that I saw, and it made me think about a couple of patients that I had who had breast cancer and then developed lung cancer that was not metastatic. It was actually a separate lung cancer. So a high percentage of people, of women who had breast cancer, had lung cancer, but they didn't actually meet the criteria for lung cancer screening. So again, perhaps over time, we're going to start thinking about other indications, but that's certainly not currently the indication. I just wanted to give you an example. So again, we're doing this next week again. We're going to do that for breast cancer and cervical cancer screening. We look forward to seeing you there. I'm going to stop screening after I show you. There's my email, 44kids@gmail.com. You can also reach out to Cancer Ontario for further support. Please don't hesitate to reach out to me if you have any questions. If I can't answer them, I have smart people that I can send the question to. So I'm going to stop my screen sharing now. We still have about 10 minutes, David. So if you want to start answering any of the questions you looked at there.
Yeah, so I'm going to try to batch them. So I got a couple of questions about screening after the age of 75 to 85. So unfortunately, this is not part of the colon cancer check program. The program is between 50 and 74, but I have certainly had patients sent to me who are over 75 who've had positive fits. So I know there's getting done. There was a couple of questions, people saying that they sent the fit in and it was rejected. I will follow that up with our provincial lead, Catherine Dubé, to find out why those would be rejected. They should not be. I mean, it's not encouraged, but it's not discouraged. Another question was, what's the definition of first degree relative? First degree relative is mother, father, brother, sister, son, daughter. That's it. So an uncle, aunt, or second degree relative, and they fall into a different risk category. People ask, what's the definition of an advanced adenoma? So advanced adenoma is one of three types of polyps. The first is if the polyp is more than 10 millimeters in size, so more than a centimeter. The second is if the pathology reveals this to be a tubulovillous, villous, or high-grade dysplastic polyp, or a sessile serrated adenoma. So that's the second criteria. And the third criteria is the number of polyps. So there need to be more than 3 tubular adenomas or villous or tubulovillous polyps. So those are called advanced adenomas. There was a question about getting pathology, that the family physicians sometimes or often don't get the pathology from the polyps that have been removed. So I know in North York, for sure, the family doctors are supposed to get a copy of all pathology that goes out. And I know that does happen, and unless somebody on the line can tell me differently, but I will reach out to the other hospitals in our LIN and find out if those are being sent. I do not know about the out-of-hospital facilities about whether they sent the pathology to the family physicians, and I can take a poll of them to see if that's being done. What else?
While you're looking, I'll answer a couple.
Okay.
I know there's frustration that right now it's only those 4 centers that do the lung cancer screening, other than the Brampton, which also makes 5 overall, 4 in the GTA. That's what we have now. So it's coming, and I'm working very hard on trying to make sure it's happening in our region at the very least, and so are others. So hopefully we will have that in the near future, but funding has to happen as well. So that's coming in terms of getting more places where you can send people, because it's a long way to go down to UHN from out here in Markham and Newmarket and Aurora and so on. David?
Yeah, so there was a question about a patient was sent fit positive, sent to South Lake. They didn't accept them. I will follow up on that. So Jack, if you want to email me with some details, just so I can follow up and see, I'm happy to do that. Are there any people without a primary care physician to have a fit test? I think, Alan, you may be able to answer this better than me, but we have discussed this issue at our meetings. We have meetings every couple of months to discuss endoscopy and fit in our central region, and this was an issue that was brought up, and I understand, Alan, it's being pushed up the chain to deal with this, because there are many people who don't have family physicians, and these patients should not be put at a higher risk than the rest of the population.
So we're absolutely working on trying to. It's already happening with breast, because once you're into the breast program, then you're automatically stay in it. And what happens if people have no family doctors, the family doctors retire or die, those results have to go to somewhere. So they end up coming to me, and I have to end up dealing with that patient and take care of it. So for colorectal cancer screening, we're also trying to get that arranged and trying to have a mechanism for patients to be able to get it. And it's tricky because there's a lot of responsibilities there, but it is being worked on right now, because as David said, a lot of people without family doctors. So we're working on that right now, trying to make it happen. I agree, it's a problem.
Noah was asking me about the size of the adenoma. So unfortunately, there's also often a difference between the size that's mentioned in the endoscopy report and the size that is mentioned in the pathology report. Unfortunately, when you send something to pathology in formalin, the polyp will shrink. So the more accurate size, in fact, is the colonoscopy report. And part of standing reporting there should be a size mentioned. We try to all standardize our reports. Some of us do it better than others, but size is certainly one of the major criteria in a report. So look at the endoscopy report, not the pathology report.
So what David says is size matters. Okay, I'll move on from that. Michael, your point about lung cancer in non-smokers is important. Up to 10 and even 20% in some series of lung cancers are in non-smokers. Recognize that secondhand smoke and thirdhand smoke is a risk factor. Recognize that radon is a factor as well. Screening for those people makes it really hard. I gave it an idea of who would be some other people who are high risk, such as people who have already had breast cancer treated or higher risk. So screening for that population, Michael, right now is not going to happen. You can make the point, well, what about cannabis and non-cigarette smokers as well, and other things they put into their lungs, all of which are very reasonable. So these are, again, these are important issues, but the data that we have for lung cancer screening working is all in that smoking population for now. So I don't think very soon we're going to have any other kind of screening, although I agree it's a problem. I think what's really important for us in primary care is to have a very low index of threshold to go investigating someone with any symptoms at all. That cough that doesn't go away, the pneumonia that doesn't resolve, as I said before. So please think about those as risks. Melina asked about how often to do the testing for. Is it, so I asked about the criteria in the requisition form, and you've had patients rejected. Well, the reason for that, as I said to you, is because they do a separate risk assessment beyond just the criteria of age and the number of pack years. And they're doing that to try to keep the numbers down to a number that's a reasonable number that's going to make a difference. So those initial studies were very sort of broad, and now they're making them a little bit more narrow. So I agree it's a bit annoying to go through the whole process of referring that for them. And what I add in my conversation to the patients that I send is that it's important for us to recognize that only the people that need it should be going for these CT scans on a yearly basis for a little while. And it may be that you're going to be considered low risk and not go for it. So you've prepared them for that to happen. And Carrie asked about how many years to go on for. The study was 3 consecutive years. The National Lung Screening Trial was 3 consecutive years. However, on speaking to the TGH people, they actually keep doing it. It's interesting because they're not really funded for that. But as of right now, if patients want to keep doing it yearly, they will keep doing it yearly. So it'll depend a little bit on who they're seeing in the program, and if the patients decided they wanted to do it. But if you have someone that you want to stay in the program, I think all you have to do is ask. David, back to you.
Yeah, so this is a great question. Is it standard of care for physicians who does a scope to send a note back with follow-up plans? So yes, that is good care. That should be the standard of care, that you should send a follow-up. But I'm going to say that with a caveat, because what I told my patients 5 years ago, and what I wrote back to the family physician was, this patient had a low-risk adenoma, he should have a colonoscopy in 5 years. Well, that's no longer the guidelines. So yes, I think follow-up should be mentioned in the note, on the understanding that guidelines change, and that even though we said 5 years ago, that may not be what's appropriate today. And in 5 years from now, who knows what we're going to be doing? Things may be very different than they are now. So you have to be wary of the response and what the recommendations are, and put it in the context of today rather than 5 years ago.
And there's frustration from a lot of our colleagues about getting different responses from especially people who are private clinics than what's happening from people who are in the organized program, such as David at North York, Brian Stotland's at Southlake, and so on. So that is a frustration. And I think sometimes I have to actually speak to these people and call them out on their recommendation. Otherwise, what we're telling them is different than them. And I've been finding that most of them are quite reasonable to have that conversation, accessible to have that conversation. Yulin asked about symptom suspicious lung cancer, do a chest X-ray or a low-dose CT or a regular CT. I think I would always start with a chest X-ray because you can get that done literally the same day. Start with that. But if your chest X-ray is normal, but you're still suspicious, for instance, a non-resolving pneumonia where you might need to have a CT or even, frankly, a bronchoscopy to see if there's an endobronchial lesion, then you carry that on as far as you need to. If you're going to investigate, I would do a regular CT, not a low-dose CT, because you want to have the intravenous contrast to better outline the lesion. So again, that's not screening. It's if you're worried about it, then you do a chest X-ray first. And if you're still concerned, then go on to a CT would be the answer, plus or minus a bronchoscopy. Again, even a normal CT, if someone with hemoptysis still should have a bronchoscopy, for example. And Paul asked about vaping, and vaping is something else that shouldn't go in the lung. That's a whole other conversation by itself. But vaping is depends on what you're vaping, right? So we learned about that disease of lungs, the fibrotic disease that was occurring with vaping, that occurred with cannabis and vitamin E, and that was killing young people. Vaping, if it's going to be cannabis, is worse than without cannabis. If you're talking about people about smoking cessation and you want to advise them to use e-cigarette, tell them to use it with no flavor, no color, no cannabis, and the risk of that is very minimal and certainly less than cigarette smoking. David, back to you.
I think that's all I had. Oh, one, there was a question about starting at age 45. So in the States, this is now the recommendations. is that we should start screening at 45 rather than 50, because we are noticing a trend in younger and younger patients. This is not the recommendation in Canada yet, but it may come.
Okay. Listen, I'm sure there's a whole bunch of other questions we've thought about. I've tried to answer some of them in chat and some of them as we've been going, but there's a lot of you out there, which is fantastic. Again, if you're having problems with this, both David and I are quite happy to hear your issues and to see what we can do about fixing them. We're dealing with a large process when you're talking about Cancer Care Ontario. It's a government agency. It doesn't necessarily move fast, but it does move on the advice of people like us. So please feel free to reach out to us about those issues. I'll throw my email into the chat. I don't know, David, if you want to do that or not as well. And we're just a couple minutes over time. I want to respect your time. So I think unless there's any other burning questions that anyone has, in which case put up your hand and I'll let you unmute. Otherwise, I think it's probably time for us to return to our lives. David, any last comments from you?
Nope. Just have a great winter. Be careful. Don't fall.
And wear masks and take care of yourselves and get vaccinated.
Stay
Okay.
healthy.
All right. Okay. Good night, everyone. I want to thank Rakaya as well for getting all this done behind the scenes. So again, she's been invaluable. So again, thank you for that, Rakaya. I know that you will not unmute yourself and you will not put your video on to show everybody who you are, but trust me, she's a gem and a wonderful, and we're very happy to have her. So thanks everyone. And thanks David again. And again, stay safe and be active in preventative care. That's our job. And screening is a good part of that. So thank you again for all your attention. We did that in an hour, David. That's pretty impressive, man.
Yeah.
Yeah, great job.
Thank you, Rakaya. You can put my email address in the note, Rakaya, if you
Okay, sounds good.
have questions. I'm more than happy to answer.
Okay, I guess we can end.
Yeah. Okay. Well, David, again, always a pleasure.
Thank
Thanks
you.
for, thanks for being so organized.
I learned a lot. I didn't know much about lung screening, so
Unfortunately, most people don't, and that's an issue. But it's also, of course, that we only have a few places we can send. So we really, as Rakaya knows, I go on and on about the fact that we need to be able to do this in more places. And that is a very huge barrier for it. So hopefully
to do it every year, to start off, it's okay. But if you have to do all these patients every year, we're going to run out of resources, right? I mean,
that's why it needs the separate resources for it. It needs to have a dedicated program with the resources to do it. But it is an issue. But they managed to do it in Brampton. They set up their own, no funding from Cancer Care Ontario at all. They're doing a fantastic program with results just as good as TTH in terms of results. So with good surgeons, and we have great surgeons at South Lake. Really great thoracic surgeons. So I think we can do it there too. So hopefully it's going to happen soon. So.
All right, guys. Thanks. Have a great evening.
Okay. Good night, everyone.
Okay,
Good night.